Okay, so we are going to talk about anti-tuberculosis drugs, and then so anti-tubercular drugs are used to treat tuberculosis. We all know that tuberculosis is caused by Mycobacterium tuberculosis. And what the drugs do is to halt the progression of the mycobacterial infection. Apart from being active against Mycobacterium tuberculosis, they also they are also effective against the less common mycobacterial infections by Mycobacterium cancerci, Mycobacterium avium intracellular, and Mycobacterium fortuitum. I'm sure you came across those in microbiology. Unlike most antibiotics, anti-tubercular drugs may need to be administered over many months. And when this happens, there are peculiar problems that arise as a result of this prolonged duration of treatment. And some of these problems are patient non-compliance, development of bacterial resistance, and then drug toxicity. We all know that the longer you take a medication, the more likely that you have the side effects. And with the non-compliance, I mean, being on the medication for months and months, patients are likely to get tired of it. And the longer the bacteria is exposed to the medication, the more likely that they will be able to undergo some genetic mutation and develop resistance. So to combat this, a direct observed therapy was proposed because treatments can go on typically for as long as 6 to 9 months. And so this is what necessitated the directly observed therapy. Now, directly observed therapy observes the patient take every dose of medication for the duration of therapy. So what happened is that you have these Ministry of Health TB treatment centers where the patient goes every day to take the medication. Once the health worker observes the patient take the medication, they take the patient's records. And this goes on every single day until the patient is done with their 6 to 9 month course of therapy, depending on what type of tuberculosis they are treating. Now, in some advanced countries, a controversy exists over whether every individual with TB should be observed, that is universal DOTS, or whether it's only the patient who is at risk for poor compliance who should be observed, and that's selective DOTS. But here in Ghana, what we adopted was the universal DOTS. So some of the patients who may be at risk for poor compliance include a patient who generally has a history of poor compliance. So maybe from the history, you realize that this is a patient who has poor health-seeking behavior, or who is not very attentive to their medication use, or a patient who has drug or alcohol abuse issues, a patient with mental illness, and then a patient who is homeless. So for some of the centers, they evaluate a patient's ability and willingness to comply before they enroll them in the DOTS. And ideally, once a diagnosis of tuberculosis is done, we put the patient through what we call adherence counseling, whereby the patient is told about the duration of treatment, what the treatment entails, some of the side effects. And we also advocate that this patient should bring along one relative or one person who would be like their advocate to help make sure that they comply with the medications. So we are not really going to talk about diagnosis of TB and all that. I'm sure you've done that in your internal medicine already. So traditionally, once you make the diagnosis of tuberculosis, the patient is put on drug therapy, which involves Isoniazid, rifampin, ethambutol, and then paraxinamide. And these have prevented the emergence of drug resistance. Now, because of the current evidence of drug resistance strains, we usually recommend a 4-drug regimen for the initial treatment. So we have isoniazid, rifampin, paraxinamide, and then either streptomycin or ethambutol. If, let's say, the local testing shows that maybe there's resistance to these medications, 1 or 2 of them, then we need to modify the regimen. The common medications that bacteria are resistant to are the isoniazid and the rifampin. And so if you have this, then you may need to increase it to about 5 or 6 drugs as the initial therapy. And this is when we say that the patient has multi-drug resistant tuberculosis. But for the normal TB, which is susceptible to the anti-TB drugs, we do a 4-drug regimen. And because there's a greater incidence of toxicity, there's a second line of medication. If you realize that maybe the patient is resistant or the patient has multi-drug resistant TB, then you go to the second line, which is 5 or 6 drug regimen. But because those medications have a greater incidence of toxicity, you usually use it for patients who have the multi-drug resistant TB or who are allergic to the first line. So you don't just get up and put them on the second line. So one of the second line medications is the fluoroquinolones. So usually when you are suspecting that the patient has tuberculosis, you don't start them on fluoroquinolones, because if they turn out to have multi-drug resistant TB, you would put them on quinolones, fluoroquinolones. So you don't want the patient's bacteria, whatever bacteria they are harboring, to develop resistance to the fluoroquinolones before you may need to put them on it. I hope that makes a little sense. So usually the fluoroquinolones, but ofloxacin is more potent and may be an initial choice in retreatment of patients with tuberculosis. And they are generally administered orally and they are well tolerated. You have a lot of GI side effects like with most medications, but resistance develops quickly when they are used alone or in insufficient doses. And that is why we would usually not recommend starting fluoroquinolones for respiratory infections, because if TB is lurking there somewhere, it's easy for it to develop resistance. Streptomycin was the first drug that was recognized as effective in treating tuberculosis. And streptomycin is administered by IM, and it appears to enhance the activity of the oral antitubercular drug, and it's of great value in the initial months. Your nose is not running. Where is the nose? Yeah, it's okay. Where? But because it is IM, you don't give it for the entire 6 months. It limits its usefulness because you can't give IM injection for 6 months. That's just too much. It is when it's given IM, it is rapidly absorbed from the IM site and is primarily excreted by the kidney as an unchanged drug. It's well tolerated by most patients, but there's a side effect of the 8th cranial nerve toxicity, that's ototoxicity. So looking at the pharmacokinetics of anti-TB drugs generally, most of them are administered orally. And when after oral administration, they are absorbed very well from the GI. And from the GI, after it's been absorbed, it is widely distributed throughout the body. They are metabolized primarily in the liver and excreted by the kidneys. And these antituberculous drugs are specific for mycobacterium. And if you look at the way they act, ethambutol and isoniazid are static drugs, meaning that they just inhibit the growth of the tuberculosis. But it's rifampin that is cidal or tuberculocidal, meaning that it destroys the tubercle bacilli. And because resistance can develop to isoniazid and rifampicin, you usually don't use them alone. You use them with other medications so that it decreases the incidence of resistance. So when you look at ethambutol, the mechanism of action of ethambutol may be related to the inhibition of the cell metabolism, arrest of multiplication, and cell death. And because it acts on the multiplying bacteria, it only acts against the replicating bacteria, not the ones in the resting phase. When it comes to isoniazid, isoniazid inhibits the synthesis of mycolic acid. We know from the structure of the mycobacterium that mycolic acid is one of the components of the cell wall of the bacterium. So once the medication isoniazid inhibits the synthesis of the mycolic acid, it means that a key component of the mycobacterium cell wall is absent. And therefore, there's disruption of the cell wall and the bacteria is destroyed. Here too, it's only the replicating bacteria that appear to be inhibited. When you look at rifampin, rifampin inhibits RNA synthesis in the susceptible organisms, that's the mycobacteria. And it is also effective in the replicating bacteria. However, it may also have some effect on the resting bacteria as well. When we look at paraxinamide, paraxinamide is the only anti-TB medication that's converted to the active metabolite, which is paraxinoic acid. And the paraxinoic acid creates an acidic environment so that the mycobacterium cannot replicate. And that is how it acts as an anti-TB medication. So isoniazid is usually added to ethambutol, rifampicin, and paraxinamide. And this helps to prevent or delay the development of bacterial resistance. And this treatment regimen is used to treat patients with uncomplicated pulmonary tuberculosis, bovis, and Kansas. And like we've said repeatedly, isoniazid can easily develop bacterial resistance if it is used alone. But however, it can be given alone in patients who have been exposed to other people with TB. Rifampin is usually the first line for pulmonary tuberculosis as a combination. Alone, it is active against gram-positive and gram-negative bacteria. It is also used to treat patients who are carriers of Neisseria meningitidis when the risk of meningitis is high. So if, for example, there's a household and then one person is diagnosed with Neisseria meningitidis meningitis. Let's say you do a lumbar puncture, you get a CSF for culture, and it's culture's Neisseria meningitidis. All the household contacts will have to be put on rifampin as prophylaxis against the Neisseria meningitidis. But it is not used to treat the meningitidis. It is used for prophylaxis because it has a potential for bacterial resistance. Paraxinamide is also part of the anti-TB medications, and it has a potential to develop resistance, so it's used in combination. Okay, so this table is looking at the various anti-tuberculous medications that are given. And we are trying to look at the treatment regimen. So ethambutol comes as tablets. So the tablets can either be 100 milligram tablet or 400 milligram tablets. And the daily dosage is 20 milligram per kilogram body weight. And it's given twice a week. The maximum dose is 2.5 grams. And the adverse reactions are optic neuritis. And so the patients will have decreased red-green color discrimination. They'll have GI disturbances and hypersensitivity. So looking at the drug formulation or the dosage formulation, if you calculate the dosage that a person needs, and it is closer to the 100 milligram, then you round it up and give the patient 100 milligram. If it's closer to the 400 milligram, then you round it up. And when you are prescribing, you give it in multiples of the 100 or the 400 milligram so that you don't have to cut or break the tablets because it's usually not scored. Now, when it comes to isoniazid, however, isoniazid, the tablets are scored. Okay, what we mean by scored tablets is that you see when you take the tablet like paracetamol, you see this deep line in the middle that you can break the medication along that line. And so when you break it, you are confident that it contains half of the dosage. So for example, if you have a 500 milligram tablet of paracetamol and you break it into two, each half is 250 milligrams. That is if you break it into two equal parts along the scored line. And so isoniazid comes as 100 milligram and 300 milligram tablets, and they are scored. What this means is that if you break the 100 milligram tablets into two, you can have 250 milligram tablets. And there's also syrup, which comes as 10 milligram per ml. So in that case, you can give smaller dosages. And the dosage is 10 to 15 milligram per kilogram body weight. And you give 300 milligrams. The adverse reaction, mild hepatic enzyme elevation, hepatitis, peripheral neuritis, and hypersensitivity. Then paraxinamide is also a scored tablet, 500 milligram. You give 30 to 40 milligram per kilogram body weight. And note that they also exert hepatotoxic effects and can cause hyperuricemia, arthralgia, and gastrointestinal upset. Rifampin is usually a capsule. So you know how a capsule looks like, a typical way that antibiotics look like. So once it's a capsule, you can't divide it or do anything.
You open and drink half.
Pardon?
You open the capsule and drink half.
You see powdered granules in it. So how are you going to divide it? It is also available as a syrup, which can be formulated from the capsule. So this one is done by the manufacturing unit. Some hospitals have a pharmaceutical manufacturing unit, which can reconstitute some of the tablets into syrup. So the key thing about the adverse reaction of or urine, staining of contact lenses if the patient is wearing them, then vomiting, hepatitis, influenza-like reaction, thrombocytopenia, that's decreased level of platelets, pruritus, and then oral contraceptives may be ineffective. Now, it's very important when you are doing the adherence counseling for patients that you explain some of the side effects, especially something like rifampin, which causes orange discoloration of the secretions. It would be very scary if nobody told you, and then suddenly you start taking your anti-TB medication and suddenly you realize that your urine is orange. That would be a very disconcerting observation. So once you explain to the patients what to expect, they are more at ease when they see some of these things. So we look at the adverse reactions. There are a lot. I sort of summarize it in the table just so that you have something at a quick glance. But the very important adverse reaction of ethambutol is the optic neuritis and then the hypersensitivity. For isoniazid, peripheral neuropathy is the most common adverse reaction. So they'll have tingling sensation, pins and needle sensation in the extremities. And then they also have severe and occasionally fatal hepatitis. And so the patients must be monitored carefully because several months after stopping treatment, they can still develop the hepatitis. So for rifampin, like we previously said, the secretions are colored orange, and then you have all the GI side effects. Paraxinamide, mainly liver toxicity. You can also have GI effects. You can have hyperuricemia and arthralgia. So there are lots of drug interactions with the anti-TB medications. If you have a medication like cycloserine and etonamide, which give CNS effects already. If you take them with the anti-TB medications, the CNS effects are amplified, or there's this additive CNS effects. So you have a lot more drowsiness, dizziness, headache, lethargy, depression, and tremor when it is taken with isoniazid. Then isoniazid may increase the levels of medications like phenytoin, carbamazepine, diazepam, etotoximide, primidone, theophylline, and warfarin. And when you give corticosteroids and isoniazid together, what happens is that the steroids will reduce the effectiveness of the isoniazid, and the effects of the corticosteroids are rather potentiated. And then isoniazid may also reduce the plasma level of ketoconazole and itraconazole. Both of them are antifungal medications. And then oral antidiabetic agents. So a lot of the time, patients who are taking anti-TB medications may have some immunosuppression. And then they would also be at risk of opportunistic infections like fungal infection. So usually these are some of the things that occur. And when you take oral contraceptives with rifampin, they may decrease the effectiveness of the oral contraceptive. So the patient may need to use other backup contraceptive methods. And when you give the medications together with ethionamide, there's increased risk of hepatotoxicity. Also, phenytoin levels may be increased when they are given together. Oh, yeah. Okay, thank you. Are there any questions? Yes, I've heard your question. I really understand. So we will do antifungal medications on Wednesday. Then we'll bring the curtain down on anti-infective agents. Then we'll tackle other things from next week, God willing. Please, are there any questions?
No, please, I have a question.
Yes, please go ahead.
Oh, please, so about the adverse effect of the drugs, I mean the isoniazid, the rifampin, and the ethambutol, I mean all the adverse effects. If a patient is having those complications, is your next action is to continue the medication, or you have to deal with the adverse effect in the form of prescribing another drug to deal with it?
Okay, so some of the effects can be very severe, like the fatal hepatitis that you can develop. And so if it's a very severe adverse reaction, then you have to stop and put the patient on second line. Okay, I didn't really go into the second line because once you get to second line, it means that you have to refer the patient. So that's why I didn't go into that. But it's important for you to be aware that there are second line medications and fluoroquinolones are one of them. So you just stop and put the patient or refer the patient. But what happens is that the patient is put on second line because the TB has to be treated. So you cannot just discontinue and leave the patient alone. You have to put the patient on second line.
Okay. Thank you.
All right.
Doc,
Yes.
please, a follow-up question on that.
All
So
right.
assuming that you are able to identify one particular first-line drug which is giving an adverse effect, and in that case you want to take it out, are you going to take away all the first-line drug and start with a second-line drug, or you introduce a second-line drug, one of it, to substitute the first-line drug that you have notified?
No, you can just take out whatever offending drug there is. And because it's a multi-drug regimen. In the past, they were even just using 3 drugs. And then later they added Paraxinamide. So you can treat it with 3 drugs, but you need to be monitoring the patient to be sure that they are responding to the treatment. If not, then you may need to stop everything and start on second line.
Okay. All right. So my next question is, how will you determine a multi-drug resistant patient in terms of pulmonary
Okay,
TB?
so multi-drug resistance, when you do the sputum test, when you take their sputum for the acid-fast bacilli, you also do culture and you do sensitivity against the anti-TB medication. So if there's multi-drug resistance, you pick it up from there. Usually we don't routinely do those sensitivities unless you put the patient on treatment and the patient is not responding. That means that after 2 months of the intensive phase, you do your sputum test and the patient is still smear positive. Then you might wonder whether maybe this patient has multi-drug resistant TB. And then you do the further testing.
All right. Thank you.
Okay. Please, any more questions?
Hello, Doc. Hello, Doc.
Yes, hello.
Ma'am, please, I want to know what accounts for the duration of administration of the TB drugs.
What accounts for?
The durations. Does some people take it from 6 months, some
Okay.
more than that?
Okay, so because we are not really talking about TB, I didn't go into that. So what happens is that usually for the simple pulmonary tuberculosis and then the other extrapulmonary tuberculosis, the treatment is for 6 months. For those who have TB of the bones, the joints, and the CNS, the treatment is 6 to 9 months. So let's say TB of the spine, TB of the joints, or TB meningitis. You treat them for 9 to 12 months. Please, are you okay? Foster. I hope he's okay.
Yes.
Hello, Doc.
Yes.
Please, if you have a patient who has a chronic hepatitis and then he developed a TB along the line, are you going to start straight with the second line or you go to the first line?
I think you will just have to go to the second line because you can have very bad hepatitis and from the side effects. And once you are going to put this patient on the medication for 6 months, definitely the patient will show those side effects. So you'd have to go to the second line straight away.
Okay, thank you very much.
All right.
Please, are there any food drug interaction when it comes to the administration.
Are there any
Food-drug interactions.
good? I don't understand your question.
Food.
Beneficial drug interactions.
No, I'm
No.
asking whether there are any food-drug interactions when the patient is taking the drug and is also taking other food. Maybe the food will react with.
Food. Oh, okay. I didn't come across any food interactions when I was putting the lecture notes together. In my knowledge, clinically, not that I know of, nothing comes readily to mind. But I mean, I have been dealing with kids for a long time, so I don't know if there's something with the adults. All right. Yeah. Any others? Are there any other questions? Okay. Nick, do I owe you any notes?
No, I think you sent the.
I sent all my IRS in.
Yes.
So it's just this one.
Today's
Okay.
yes. Today's lecture.
So I'll try and be sending them ahead of time so you can go through
All right, Doc.
all the lecture. All right. Okay, then have a good night.
Have a good night, Doc.
Good night, Doc.
Bye.
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 I go say bye.
Oh, no, another one be a question.
Whenever one by anything.
Maybe a 10 in 10. No, I want.
Otiasia, why Otiasia?
And then you know 5 in 5. What's so? 10 in 10 questions. No, those.
Inti mumu wo na mo mbeka me mo honto.
Debbie.
Mumu wo na mo mbeka me mo honto.
Debbie.
Me jimia ma mente ne eyo kan inti chale ne lodo to YouTube ho wa na me gon kwhwe na me
na from Obianka Sekotna village.
Wo way ohwehwe admi ohwehwe
Ostromi.
Ostromi edwane. Brani entu oduro kakra edwane. Brani entu oduro kakra edwane.
Obejo wo de wo.
Me. Witna. Charlie, Nick, lodu to on mo channel pa my why need me enko mobi why.
I say you may maybe in part. Grandma to all you why.
I adults, Nick.
Yeah.
On fa ba ko kram to ho. Me hu so de obi udi bi ato ama.